Welcome back, everyone, from lunch. Welcome to the session entitled Latest Evidence from Trials on Imaging. This incredible session is based on several late-breaking clinical trials that was presented at the European Society of Cardiology Congress towards the end of August in Amsterdam. So really looking forward to discussing these very important clinical trials and how they apply to our daily practice. So my name is Vijay Kunadian. I'm Professor of Interventional Cardiology from Newcastle, United Kingdom, and it's my absolute pleasure to be joined by my dear friends, Dr. Nicolas Amabile and Professor Francesco Burzotta. We also have a fantastic panel together with Dr. Alessia Azzano, Dr. Biswas. I think Dr. Rony Mathew, if he's not here, then I think he's probably joining us online. We're also joined by Dr. Nam and Dr. Hikichi and Dr. Erglis. And it's also an absolute pleasure to have Dr. Ziad Ali, Professor Gregg Stone, and Dr. Park also joining us on the line. Of course, they will be doing the presentation as well as joining the discussion. So without further delays, I'm going to hand over to Nicolas to introduce the first clinical trial.
Thank
Nicolas.
you, Vijay. So as you mentioned, the year has been very exciting because of all these clinical trials, and especially focusing on the field of bifurcation. And so Professor Christiansen will present us the data from the most awaited October trials. I think this is a recorded presentation.
Dear Chairman, dear EBC, thank you for having the chance to share the October trial results. These are my disclosures. So, OCT for procedural optimization has shown to get better stent expansion, result in reduced stent malposition, and better scaffolding of the side branch osteum. October trial overview. Patient with stable or unstable angina or non-STEMI with a true bifurcation and a side branch reference at or above 2.5 millimeters. We aim for 1,200 patients randomized 1:1 with a primary composite endpoint of MACE of a median of 2 years. Target population, patients with true bifurcation lesions, left main and non-left main bifurcation lesions, enrollment of lesions with high complexity encouraged, and high-risk patient allowed, including surgical turndowns. Indication, stable angina, unstable angina, or non-STEMI. So the techniques could be used was one stent provisional with kissing balloon inflation, or two stent technique with DK crush, culotte, T-stent, or TAP, published in American Heart Journal 2018. It was an investigator-initiated study with an open label design in 38 heart centers in Europe. We had on-site training in OCT guidance and feedback on OCT guidance in all cases. We randomized 1,201 patients, and we strongly disencouraged use of imaging in the angio-guiding arm, but 16% had IVUS guidance. We had very low loss to follow-up in the trial. The patients were well balanced according to age, gender, and indication for PCI, and a low proportion of diabetes. Bifurcation location, 1 of 5 in the left main, and the rest, the majority, in the LAD diagonal. We had longer stent length in the main vessel in the OCT arm and similar length in the side branch. More balloons, larger balloons were used in the OCT arm, and 2/3 had two stent technique, reflecting the inclusion of complex lesions in this trial. There were more contrast use, procedure time, and fluoroscopy time in the OCT arm. The primary endpoint of MACE, 14.1% reached the endpoint after 2 years in the angio arm versus 10.1 in the OCT arm. statistically significant reduction with OCT. And similarly, for the patient-oriented composite endpoint in favor of OCT guidance. The trial was not powered for the components of the composite endpoint, but they were all in favor of OCT guidance versus angio guidance. Subgroup analysis did not identify any significant interactions. So we conclude that OCT-guided PCI was associated with a lower incidence of the composite endpoint of 2-year MACE compared to angio guidance in complex bifurcation lesions. The procedure time, the fluoroscopy time, and the contrast volume were increased with OCT guidance. Implementing routine OCT guiding for PCI of complex bifurcation lesions may be justified, in particular as the effect was shown with a 16% ad hoc IVUS in the control arm, and despite the COVID-19 pandemic affecting the invasive follow-up. We contributed with the results in this updated meta-analysis of angio guidance versus imaging guidance of PCI. 22 randomized trials were included in the meta-analysis with nearly 16,000 patients and more than 2 years follow-up. And the primary endpoint in this analysis was target lesion failure. And we saw significant reduction by imaging guided PCI, target lesion failure of 29%, cardiac death 45%, target vessel myocardial infarction 18%, ischemia-driven target lesion revasc 28%, stent thrombosis 47% reduction, and for the first time, reduction in all-cause mortality of 25%, and also reduction in any myocardial infarction. There were no statistical and meaningful difference between the use of OCT versus IVUS in this meta-analysis. Thank you for your attention.
So I think, Francesco, what we can do is now moving to Professor Holm's presentation and then have a common discussion about the October results.
Thank you very much. Can I have my slides? Thank you very much. So, thank you very much for the kind invitation. These are my disclosures. So, October is an imaging trial, meaning that the subsequent data on bifurcation techniques are descriptive and hypothesis generating. We asked the physicians to enroll patients with a need for either one-stent strategy with kissing balloon inflation or a two-stent technique. So in the October trial, it was about 35% of the cases that ended up having a one-stent with kissing technique, and 65% roughly had a two-stent strategy. The reason why we focused on this technique was that in our previous work, we have seen that two-stent strategies, there was certainly a room for optimization, but also in single-stent techniques with kissing, because we saw that with kissing balloon inflation, we got a good sidebrains result, but something happened in the main vessel that caused MACE events, even including death. So, when we look at the October results stratified for the treatment, we saw a 50% reduction in MACE with the one-stent techniques. So actually, with 6% MACE after 2 years with kissing balloon, with kissing 1% one-stent technique and kissing, which is very much in line with just regular stent technique results. With two-stent techniques, we only saw a 14% reduction in MACE and was non-significant. And we here in 2 weeks at the TCT will present results with some insights in why we did not see a major effect with two-stent techniques. In one-stent group, the physicians really did a fantastic job following the protocol for OCT guiding, whereas with two-stent technique, we saw more variation, and in particular, as our learning curve was disrupted by the COVID-19 pandemic. So the OCT protocol was based on 4 treatment goals: optimal lesion coverage, no stent malposition, optimal stent expansion, and no unattended stent deformation. The OCT protocol, is spelled out in in the supplement to our methods paper that's published in American Heart Journal, so you can download it there if you wish to read it. Here we had this stepwise approach with a checklist-based evaluation of the OCT scans throughout the procedures. The timing is very important because you can do OCT at any time point during procedure, and that's not feasible. So we recommended to do the first pullback after plaque preparation, but before stent implantation, to evaluate the plaque preparation, establish the landing zone, the stent length, and the stent sizing. And then after each rewiring, to evaluate the wire position, both crossing into the side branch, but also to follow the wire all the way out of the stent to check that there is no accidental abdominal rewiring. And then the final result, to check for lesion coverage, expansion, apposition, and stent deformation. So an example after plaque preparation to the left, no effect as seen after plaque preparation, so the physician decided to go on and perform more plaque preparation here using non-compliant scoring balloon. We saw the core lab saw that after the first OCT pullback, there was a need to do additional plaque preparation in about 50% of cases, and the physicians actually performed more preparation in about 41% of cases. So the physicians were also asked to plan the stent to avoid residual stenosis in the edges, avoid major fibroatheroma and major dissections based on the available evidence at the time. And the reference size had to be established based on media-to-media measurements for all segments. But of course, if OCT was not performed, it had to be a angio-based evaluation based on the visual estimation. The reference diameter was also the limit of the largest balloon. The large balloon was larger with OCT guiding, whereas the incidence of perforations was similar in the two groups. So after rewiring, we checked for the wire position. It was not that granular, so we just wanted to avoid the wire going in a very proximal position as it would cause a long metallic carina. And then we followed the wire all the way out of the stent to check if the wire was abluminal, because of course a dilatation would cause unintended stent deformation. And then just another example of abluminal rewiring. And then the final result, we checked for lesion coverage to ensure that the edges was fine. We have a sub-study coming out on that, to try to reproduce the Kang study with IVUS. And then expansion. We know that the angiographic ambiguity is very high in bifurcation assessment. So this is the ostium of the side branch of the diagonal in this case. And you can clearly see the stent is severely underexpanded, which was not evident from the optimal angiographic result. And we used the the reference size that was established at the beginning of the procedure when we evaluate the expansion of the stent. Because if we use a lumen-based evaluation as the AptiView system does, then we can get a relative reference that is overestimated. In particular, if you have diffuse disease in the edges, using a lumen-based reference at this time of procedure can really cause problems. We showed in a publication this summer that is really a dramatic difference in the evaluation of stent expansion. So, and then we aim for no malapposition, and yes, really, but it was not like we chased malapposition. We just mandated one additional attempt for correction after the final pullback if there was still malapposition. You could see there are no references, so it was based on the idea that malapposition is more problematic in bifurcations, but also that that this patient population would have a higher risk of stopping dual-lateral plated therapy at an early time point. So, and then finally we look for unintended stent deformation. Two major causes were accidental cross by guiding catheter collision, but also due to accidental abdominal rewiring. It was clearly related to increased MACE, and if it was identified and corrected, the risk was reduced. So all this combined led to the 30% relative risk reduction. It was based on 3 hours of training before entering the study, and then feedback on the individual OCT-guided cases at least in the 4 or 5 first cases, and then a bit more ad hoc. We're absolutely sure that we underestimate the true effect of OCT guiding due to the disruption of by the pandemic. And is it needed to do a better job? For sure it is. We have just been downgraded to 2A for left main bifurcation PCI, so we need to do our very best to get up again in our quality, and we need to use OCT guiding for that. So in conclusion, OCT-guided bifurcation PCI was associated with improved clinical outcomes, 1 stent with kissing, clear effect of OCT guiding, 2 stent techniques, not so much, more variation in procedural quality, unintended stent deformation due to guiding catheter collision or accidental abdominal rewind contributed to MACE. If we correct it, well, we saw virtually no MACE events. Implementing OCT guiding for PCI of complex bifurcation lesions may be justified, in particular as the positive effect was shown, 1, despite 60% ad hoc IVUS in the anchor arm, 2, despite suboptimal OCT guiding, and 3, despite COVID-19 pandemic affecting invasive follow-up. Thank you very much.
Yeah, thank you very much, Niels. So these are very interesting and exciting results, and I'm quite sure that the panel and the attendees will have some questions for your team.
Thank you for some great presentations. I think the finding that OCT improved outcomes over angio guidance only in 1 stent techniques, but not so much in 2 stent techniques, it's really interesting because it goes against the common thinking that the more complex the procedure, the more complex the lesion, the more that we have to gain from imaging guidance. And then I think with the point you made about the fact that maybe it was due to suboptimal use of the OCT guidance is interesting because we know from IVUS trials that it's not just using the OCT or the IVUS that makes a difference. You actually have to know what you're looking at and react appropriately to the data that you're given. So I wonder if you had any insights or was there any interaction between whether the MLD max kind of targets were achieved and whether protocol was followed versus not in terms of the improvement in outcomes seen?
Yes, so with 1 stent technique, as I explained in the beginning, there's clearly a relation between optimal procedures and then an optimal outcome. With 2 stent techniques, we started to see some effects that we know. For example, in this room, we have 5 colleagues that joined the trial, very high level. They were on top of the learning curve when they entered the trial and did a fantastic procedure, textbook procedure throughout. But we also had a lot of physicians that joined the trial quite late, just before COVID, and maybe was somewhere on the learning curve when COVID hit. And then it was very difficult due to the cath lab environment. I think a lot of people in the room can appreciate that was a difficult time. And then, maintain the skills level with, longer time between, longer pause between the procedures. So we can see that the quality of those procedures were, with larger variation, and maybe even that procedures that should have been staged, simply not finalized because there was a pressure to do short procedures during that time. Maybe another stent should have been implanted to finalize it, and they were simply not staged that procedure despite it was part of the protocol. If you do not finalize, if you need to do more, you can easily stage the procedure. But that was not done in a number of procedures.
Okay. Just one comment. You say the simpler procedure. However, 1 stent procedures in kind of patients like that, I mean, a true bifurcation, so with extended lesions in the side branch, is not simple. This is, to me, important to be remarked because the complexity of the lesion was present in all the patients that were enrolled in the trial. This is very important. And to apply 1 stent when you have extensive disease is really, something that can be probably done mainly if you have OCT guidance that check that you did it properly.
So Niels, many, many congratulations. It's a fantastic study, and it's not really easy to do, to bring a study to a completion, particularly in the context of the pandemic. So really well done to yourself and the whole team. My question is, we are going to discuss comparison of OCT and IVUS. So what do you think your results would have been if you had a third arm of, say, IVUS? Do you think the curves would have been different, or would they have been on top of each other? So that's my first question. And then you mentioned about the guidelines. So obviously the guidelines were written before all of these trials came about, and we have a recommendation of 2AA right now. So how, you were saying maybe upgraded, so clearly for other patient subgroups, this is, we have different results, so bifurcation, clear results from your study. So what do you think, in terms of the impact on guidelines and clinical practice based on your study?
Yeah, so two big questions, but first to the IVUS versus OCT, I believe that we have the OCT-IVUS trial very recently also at the ESC showing that there's almost similar outcomes with the two trials that also focused on complex cases. It was kind of all comers, but there was a lot of complex cases in that trial. I still believe that OCT has the upper hand in bifurcation treatment, because when you have more stents implanted and when you want to check for wire positions, the higher resolutions do add some ease of interpretation, in particular when you start to use 3D, and we can that can be more helpful also with the next generation systems that we will have, faster pullbacks, more ease of use, and so on. So I think, again, with OCT, we'll have the upper hand in complex bifurcation stenting. But if you're really proficient IVUS user, you can absolutely also do a good job. It's much better than doing angio alone.
Yeah, Niels, thank you very much, and it's a great study. We are happy, I guess, at least 1/10 of patients are sent in this study, and as you know, we are for so many years together with Nordic program of bifurcations. But actually, regards to imaging, and it is, I guess, for me, it's a very, very important question, and it is not only question we use or not to use imaging. For me, and I also tried yesterday to dive deep in study, but I didn't find this. But could you say what is a percentage why, based on imaging, operator change mind, actually change and pre-treatment, post-treatment, or even use other technique? Because I guess it is most important point. We are not talking about that we need to use intravascular imaging.
So we cannot really answer that question. That has been investigated in other studies. What is your decision based on the angiogram, and what is now you get the OCT information, what is your decision then? We didn't detect that in the OCTOBER trial. We simply asked physicians to use OCT guiding fully. We can then see, of course, subsequently that we asked, for example, here with the plaque preparation, we asked the physician to evaluate that, and then suddenly they did something more. Also, when they did the final pullback, they thought they should only do the final pullback when they're really sure, now I'm done, and then they had to do something more.
But maybe it's the reason to count it, and actually maybe to go and to analyze this one.
Yeah.
What is the percentage? What is the number when we really use imaging? Otherwise, it's pullback for pullback, it's art for art.
So at TCT here in 10 days, we will present those exact data.
Okay. If I comment on your question, what we observed in the Lemon registry like a few years ago was that the percentage of case in which the operators changed their mind according to the OCT result, where it was in left main intervention, was 26%.
Excellent, and that's because I guess discussed this 2 years ago actually in the EBC as well. But this is important, and we need to know, because this is the answer why we use imaging.
Okay, so we close here. Thank you. And thank you very much. I think that the October group should be congratulated. And now we move really, as the host for EBC, I really thank our colleagues connecting from US. We have Professor Gregg Stone and Ziad Ali that will refer about the ILUMIEN IV that was published on Parallel. So we will start with Gregg Stone. Thank you for joining. We hear your presentation, and then we look forward to have a discussion with you.
Hi, this is Gregg Stone from the Mount Sinai Heart Health System in New York, and it's a pleasure to give you this talk describing the principal results from the ILUMIEN IV trial, which we just presented at a hotline session at the ESC annual meeting and published simultaneously in the New England Journal of Medicine. And it's a privilege, really. I'm presenting this on behalf of Ziad Ali and Ulf Landmesser, who were the principal investigators for the trial, and I had the privilege to be the study chairman. These are my relevant disclosures. So in ILUMIEN IV, we randomized 2,487 patients who were at high risk because they either had diabetes or one or more high-risk lesion characteristics, which I'll show you on a subsequent slide, at 80 sites in 18 countries. This is the largest prospective randomized intravascular imaging trial to date. And the patients were randomized one-to-one to either OCT guidance using a very specific OCT stent selection and optimization protocol that we developed in ILUMIEN III and have subsequently refined, versus standard angiography guidance. And of course, in the OCT arm, all patients had iterative use of OCT, including a final OCT run. In the angiography guidance arm, they only used angiographic guidance, but we actually performed OCT as a final run once the operator said, that's it, I'm complete, I'm finished. And the results of that OCT run were blinded to the operator. We had two primary endpoints. The first was acute minimal stent area powered for superiority in the OCT compared to the angio arm. And the second was target vessel failure at 2 years. These were the qualifying lesion characteristics. About 40% of the patients had medication-treated diabetes. And among the complex lesion characteristics, which you can see are all here, the number one was long or multiple lesions requiring greater than 28 millimeters of stent, and a culprit lesion being a myocardial infarction. Now, this is the EBC meeting, and I will point out that we did have an inclusion criteria for 2 planned stent bifurcations. So where you're going to stent both the main vessel and the side branch, but this condition was only present in 3% of the patients. By core lab assessments, you could see there was a balance between all the characteristics in the group. The reference vessel diameters of the lesions were 2.93 millimeters. The lesion lengths were pretty long, over 30 millimeters. And this was the one thing that was slightly imbalanced. It was about 3 millimeters longer in the OCT group than in the angio group. I'll also point out that more than 30% of the lesions were severely calcified by OCT core laboratory analysis, balanced between the two groups. OCT guidance compared to angio guidance led to the selection of substantially longer stents, larger stents, more and larger post-dilatation balloons. The device sizes were larger. The maximum inflation pressures were also increased. All the things that we've seen from prior OCT and intravascular ultrasound studies. OCT was associated with about an 18-minute longer duration of the procedure, with slightly more fluoroscopy and radiation use, and about 30 cc's more of contrast. Also pretty consistent with prior studies. The primary imaging endpoint was the post-stent minimal stent area by OCT at the core lab, and this was substantially larger in the OCT group compared to the angio group by about 0.36 millimeters squared, p-value of less than 0.001. In addition, when you look at other parameters which have been associated with adverse outcomes, they were also less than the OCT arm. So major dissections were less with OCT guidance. Major stent malapposition was less with OCT guidance. And major tissue protrusion, most of which probably represents thrombus, was also less with OCT guidance. We also had less untreated reference segment disease, and particularly less focal reference segment disease with OCT guidance. There were fewer angiographic complications as assessed by an angiographic core laboratory in the OCT guided arm compared to the angiographic guided arm, particularly fewer procedure-related thrombotic events. There were very few catheter-related complications by using OCT, so this was a safe procedure. Unfortunately, the overall primary clinical endpoint of target vessel failure was not significantly different between the two groups. There was a non-significant trend towards a 10% reduction in the hazard of target vessel failure at 2 years in the OCT group compared to the angiographic guidance group, but this was not statistically significant. When we looked at all the different subgroups based on the qualifying lesion characteristics, we also saw no significant interaction between the two groups. And again, this is the EBC club, so I will point out in the small number of complex bifurcations, the results were similar in those lesions compared to the non-bifurcations. So this was quite different than EBC, but again, the number is extremely small, so the confidence interval extremely wide. Now, cardiac death went in the right direction, a non-significant trend towards a 47% reduction in cardiac death, and target vessel myocardial infarction went in the right direction, a 23% a trend towards a reduction, but again, we weren't powered to show differences in these safety endpoints. The reason that target vessel failure was negative was because ischemia-driven target vessel revascularization was identical between the two groups. This rate was actually lower than we had anticipated, and again, absolutely identical, no difference whatsoever, despite the larger MSA in the OCT-guided group. Now, stent thrombosis, obviously, the major complication, a pure iatrogenic complication of stenting, was significantly reduced in the OCT-guided group compared to the angiographic-guided group from 1.4% down to 0.5%. And that was a 64% reduction in the hazard, p-value of 0.02. Notably, death or myocardial infarction occurred in 22 of the 23 patients, or 96%, with stent thrombosis. So all the safety parameters went in the right direction. Cardiac death, TVMI, and stent thrombosis. It's just ischemia-driven TVR and TLR that were not different. Why might this be? We don't know for sure, but one of the very possible things that happened was the COVID pandemic. About 80% of the patients were enrolled and followed up mostly during the COVID pandemic. And in the pre-COVID period, you can see there was about a 30% reduction in target vessel failure, at least the trend towards that, as we had anticipated. But in the COVID period, you could see the curves were superimposable. And the biggest difference here was in target vessel revascularization. And remember, TVR is a decision. It's not an actual event. And what we suspect happened was that during COVID, cath labs were closed and physicians and patients were electing, even if they had recurrent angina or a positive stress test, not to come back for repeat revascularization. So that might have led to the very similar ischemia-driven TVR rates during COVID. So in conclusion, OCT guidance of PCI resulted in a larger MSA than angiography guidance with greater stent expansion. OCT guidance led to fewer major dissections, major malapposition, major tissue protrusion, and untreated focal reference segment disease. OCT guidance reduced angiographic complication driven by fewer intraprocedural thrombotic events. The 2-year rates of target vessel failure, however, were not significantly different between OCT-guided and angiography-guided PCI. Consistent with prior intravascular imaging trials, there were numerically fewer cardiac deaths and MIs with OCT guidance, and OCT guidance significantly reduced stent thrombosis by 64%. However, despite enrollment of high-risk patients and complex lesions, the 2-year rates of target vessel revascularization were lower than expected and nearly identical with OCT and angiography guidance, a finding that was possibly impacted by the COVID pandemic. Thank you very much for this opportunity.
Thank you very much, Greg. We will hear also the other presentation, discuss together the entire trial. Other presentation.
Can you bring Dr. Ali's presentation, please? Or I don't know if he's doing it live.
I'm going to go live.
Okay.
Okay.
Over to you,
Hello,
Ziad.
Hi. Can everyone hear me okay?
Yes, we can hear and see you very well.
Great. So I'll get started. Well, always nice to chime on what Greg talked to you about from the clinical side. I'm going to talk to you about what we didn't really talk about either at ESC or in great detail in the New England Journal of Medicine, which is the optimization protocol. These are my financial disclosures. Now, I think we should step back and remember why we designed ILUMIEN IV, and that was on the premise of a series of trials called the ILUMIEN series of trials. We designed ILUMIEN III because up until ILUMIEN III, all previous studies comparing stent sizing using a lumen-guided OCT strategy to either IVUS or angiography by any strategy led to a smaller minimal stent area or minimal lumen area by OCT guidance. So OCT was disadvantaging itself by using the lumen compared to IVUS, which was using different sizing measurements, and even to angiography where operators were guessing. So we designed a novel stent sizing protocol where we used OCT guidance to try to match IVUS guidance and be superior to angiography in achieving a post-PCI minimal stent area. And the rationale was behind this was that the minimal stent area remains, as we've seen over and over again, the most important long-term predictor of clinical outcomes. In ILUMIEN 3, we had 3 arms of 150 patients each, OCT, IVUS, or angiography. In the IVUS or angiography arm, you could basically do PCI like you normally did. But in ILUMIEN 3, we asked the OCT group to follow a specific implantation and optimization protocol. And essentially what we did in ILUMIEN 3 was ask the operators to find arteries that had at least 180 degrees of external elastic lamina, if they could use that, to use the smallest mean EEL diameter. And if they couldn't, because there was diffuse disease, to use the lumen, but to downsize based on the lumen. So this was EEL and downsize and lumen and downsize. And then we use the OCT automation. For optimization, what we would do is ask the operators to implant the stent, see if there was angiographic success, and if there was not, do a post-PCI OCT. And if we didn't achieve the target minimal stent area, we asked them to enter into this loop of post-dilation with bigger and more iterative post-dilation balloons. And OCT, in regard to the primary endpoint of the study, did end up becoming non-inferior to IVUS. So this was a major finding because it was the first time that OCT matched IVUS in terms of the MSA. But we didn't find a difference, and we didn't have superiority against angiography guidance. We did have a trend, but we didn't meet it. So we stepped back after ILUMIEN 3 and thought, well, why could this be? Why wasn't OCT better than angiography for MSA in ILUMIEN 3? Well, it turns out when we took a deep dive into the study, we found that only about half of the operators followed the protocol for OCT guidance, and half of them simply didn't. And this clearly could have impacted the findings of the MSA in the angiography guided group. As Gregg showed you in ILUMIEN 4, we iterated not only the OCT guidance protocol, but also the type of patients that we were going to include in order to optimize the likelihood of benefit in the most complex patients and complex lesions. Essentially, ILUMIEN 3's OCT guidance protocol is what developed into what is now known as MLD Max, where we asked the operators to focus on morphology, length, and diameter for the pre-PCI strategy phase, and for the post-PCI optimization phase to focus on medial dissection, apposition, and expansion. And really, these were the things that we had found in ILUMIEN 3 had abnormalities and were correctable. So what we did is we decided, first of all, to split up the artery, unlike we did in ILUMIEN 3, which was splitting the artery in half, into segments. And that segment took into account any bifurcation that was 2.5 millimeters or larger. Now, instead of saying you need to see at least 180 degrees of EL, we said as long as you can make a measurement across from the vessel wall, you should use the EL. And moreover, because we learned of the safety of lumen-guided stenting, we now asked operators that if they were going to stent by the lumen, that they rounded up rather than round down. We asked the operators to use the distal stent distal measurements to provide stent and post-dilation for the distal half of the stent. And in the proximal half, we asked the operators to do exactly the same exercise to preemptively pick their proximal optimization balloon, irrespective of whether it would be a bifurcation PCI or not. And if the operators ended up with an underexpanded stent, to simplify things, we simply asked them to follow the same algorithm in the segment of stent that had underexpansion in the post-PCI OCT. So essentially, It was a repetitive and iterative scheme. Now, what was new from ILUMIEN 3 is that we made expansion both acceptable and unacceptable. Rather than being greater than 90, we went to 80. For improved efficiency, the stent diameter, length, and post-dilation balloons were all chosen immediately following the pre-PCI OCT. We had larger lumen-guided stenting. We divided the stent into segments rather than halves to account for the pot technique and to account for bifurcations. Reference segment optimization was specifically discussed. You couldn't leave focal disease at the proximal or distal edge. And we minimized the number of OCT acquisitions required. We actually said there was a minimum of 2 runs, which were the pre and final, and a maximum of 3 OCT runs without continuous cycling, intermittent and iterative post-dilation. We asked all of the operators in this 3-hour training session that we provided to understand that the expectations for success are basically on the attempt to do post-dilation rather than actually achieving an acceptable expansion. As you see, including all data, now including 3 new trials, the likelihood of you achieving the target is somewhere about 50%. Gregg showed you this study. We had about 1,200 patients in each arm, which had a valuable OCT data. So what did we learn? We learned that OCT did exactly what we expected it to. It increased the stent length, increased the maximum stent diameter, the post-dilation balloons used, the maximal device size, and the maximal inflation pressure, and pre-procedurally increased the use of atherectomy, advanced lesion preparation by 2.5-fold. And this worked because for the primary imaging endpoint, OCT led to a significantly larger MSA. Importantly, in this situation, we had incredible adherence to the protocol. Akiko Maihara was the core lab and gave real-time feedback in, 48 hours after operators submitted their cases. Also, we had 2 roll-in cases, but you'll see that the rate of optimal and acceptable was similar, but our adherence to protocol was excellent. And really what this translated to was about half of the post-procedure major dissections in the OCT group compared to the angiography-guided group, about half of the post-procedure malapposition in the OCT group compared to the angiography group, and about a 30% reduction in major tissue protrusion in the OCT arm compared to the angiography arm, and same about a 20% reduction in the treatment of focal reference segment disease in the angio-guided arm compared to the OCT-guided arm. And so this translated directly to angiographic complications from the core laboratory, which you could see were significantly lower in the OCT-guided arm. So ultimately, did it work? Absolutely. This iterative post-dilation strategy, which was simplified and serves as the basis for MLD-MAC, did in fact increase the minimal stent area, as we saw in the primary outcome for imaging. And we know that the minimal stent area continues to drive long-term outcomes. We're going to take a deeper dive on this at TCT this year and the predictor analysis on Monday, and we hope to see you there. Thank you very much.
Great. Thank you very much. We really appreciated these presentations, and it is open for discussion. Who want to start? Go.
First of all, thank you very much, and Gregg and team, and this fantastic study as well as October. And I guess it is really, really important to go forward with imaging, and as well, I'm really happy about your meta-analysis, which was presented in ESC. But could you maybe to speculate a bit that 2 years, it's too short term, and actually if we are looking on meantime interventions, and specifically if we are, for example, we have 10 years syntax study follow-up, I guess that 2 years it is a too short actually time period for follow-up. And what do you think, do we need to extend this or studies like those?
Most prior studies have shown a clear differentiation in the curves by 1 year, and they continue to spread at 2 years. So we certainly expected to see a difference then. In fact, the longer follow-up you get, especially when you're looking at endpoints like target vessel failure, you can, get dilution of effect because of progressive, plaque events from untreated lesions. We actually, as you saw, the curves did somewhat spread between 1 and 2 years in ILUMIEN 4, but then if you look carefully at those Kaplan-Meier curves, they actually started to diverge a little bit at 2 years. So I really do think that we've seen what we're going to see out of this trial. And as we showed you, the pre-COVID curves were spreading and looked like they might be continuing to spread a little bit at 2 years. And that trial would have been positive had we seen that 30% reduction in effect that we saw in the pre-COVID era. But in the COVID era, there was absolutely nothing, and the curves were superimposable through 2 years. And that was about 80% of the follow-up years of the patient. So I don't think the results would be substantially different with longer-term follow-up.
So if you have questions, please do stand up. I see there's a colleague at the back.
Hi, it's Stuart Watkins from Glasgow. Ziad and Gregg, what proportion of the patients that got into the study got into ILUMIEN 4 on the basis of just being diabetic? And do you think this contributed to not meeting the primary endpoint? Sorry about my throat.
Ziad?
Yeah, so 40% of the patients were diabetic patients. And Stuart, you're absolutely right. We, as did the Renovate PCI investigators, did not see a major interaction in diabetes. So your question is very valid and very important. But 40% of the patients that were enrolled in terms of high-risk qualifying characteristics were actually diabetic. And our baseline characteristics, 40% of the patients had diabetes.
Yeah, but remember, interaction tests, most interaction tests are looking at relative interactions. And we know diabetics have higher event rates in general for a variety of reasons. And so you're seeing a similar relative effect in diabetics and non-diabetics, which frankly is what I would expect.
So thanks, Ziad and Gregg. Again, going with the same discussion, why? We've just heard Niels and his colleague present the October trial, and you had less than 10% bifurcation. So perhaps if you had more bifurcation, do you think the results would have been different? And what is the reason behind a smaller percentage? Maybe it wasn't specified specifically in the protocol because you specified multivessel disease and diabetes in your study.
Well, we had only 3% of two-stent bifurcations, and that was one of the qualifying lesion characteristics. We actually had a substantially higher percentage of planned one-stent bifurcations, and we're currently analyzing those data, and we will report them in the near future.
Okay, thank you. We have a question from a colleague.
Question or maybe a comment, because you published in the supplement of your publication in New England that the 90% of stent expansion was achieved in 25% of patients in angiographic group and in 40% of patients in OCT group. So my question is not why in angiographical group it is so bad, but my question is why in OCT group the stents were not post-dilated and the result was not achieved in 99% or 90%. This is the question.
So as I showed that slide in terms of which I titled goals for success, no study achieves their target when using intravascular imaging. In fact, the target is a fake target. We could tell people to get to 92 or 95 or 86 or 80. What it really does is it drives post-dilation to get to the minimal stent area. So we had 42% of patients achieve 90%. We had 63% of patients achieve 80%. And really the limitation is the plaque. There's, remember these measurements are made compared to the reference segment. So there's nowhere else for the plaque to go. You further don't get any expansion. In fact, in ILUMIEN 3, we found that if you go back over and over and over again and use bigger and bigger balloons, you only get a 3% improvement in expansion, even if you use a balloon that's oversized to your reference. And that's basically because there's nowhere else for the plaque to go.
Yeah, especially with 30% of the lesions being severely calcified. You just can't expand these plaques further.
Yeah, hi Ziad. I just wanted to ask, in real world registries, we see that calcified lesions are almost 1/3. In this trial, we enrolled only complex patients, but still severe calcification was only seen in 1/3. And in one of the slides, which Dr. Gregg showed, there was significant, I think results were significantly better in favor of imaging in the severely calcified group. So do you think if the proportion of calcified patients is very large, it can be a positive trial for imaging?
Yeah, we're going to look at specifically the calcified group and report that separately. But yes, while there were no significant interactions, including not in the calcified versus non-calcified groups in terms of their relative benefit, it did tend to be somewhat better in the calcified group. And whether that is due to better lesion preparation or other features of the procedure that are different, we're going to look into in detail. I suspect it can be made even better than that, frankly. And I do think personally that calcified lesions are one area that can really benefit from intravascular imaging, particularly by OCT, because this is where you can really see the depth and extent of calcification and see the effects of lesion preparation.
Also, just one observation from the data that you showed is the stent thrombosis was different, and they all seem to be occurring in the early stages, and after that, it's pretty flat. So the impact of OCT is on preventing stent thrombosis is much earlier than downstream.
Yeah, that's a really important point.
Every study, 70% of the stent thromboses are always within the first 30 days for the most part. Although the curves did spread a little bit over time, and there were almost no late events in the OCT arm and a few late events in the angiographic guided arm. But you saw OCT also had the benefit of reducing intraprocedural thrombotic complications and major tissue protrusion, which is, again, related to thrombus in most cases. So I think all of that relates to early stent thrombosis. And so, yes, that is the biggest benefit, that plus the lack of dissections, lack of MSA. At TCT in about 10 days, Ulf Landmesser will be presenting a detailed OCT analysis looking at the predictors of all major outcomes, including stent thrombosis. And I think it's going to be very interesting in that regard.
Great. Thank you so much, Gregg and Ziad. Many congratulations on this great trial.
Thank you.
Okay, we will move on to our final imaging trial, the OCT-IVUS study, particularly on the bifurcation subgroup, which will be presented by Dr. Kang, who's online at the moment. So I think you've already recorded your presentation, so we'll hear that.
Thank you for inviting me to EBC 2023. I'm Dr. Do-Yoon Kang from Azzano Medical Center, Seoul, Korea. I will present the result of the OCTIVUS trial. Intracorneal imaging guided PCI with IVUS or OCT showed superior clinical outcomes compared to the angiographic guided PCI. Each intracorneal imaging modality has different imaging technologies, lesion applications, advantages, or limitations. However, data on the comparative effectiveness of the two imaging modalities for PCI guidance for a broad range of the patients with the clinical outcomes are still limited. So we compared the clinical efficacy and safety of the OCT-guided and IVUS-guided PCI in patients who underwent PCI for significant coronary artery disease, and we hypothesized that OCT-guided PCI would be non-inferior to IVUS-guided PCI with target vessel failure at 1 year. The trial was designed pragmatically, and 2,000 patients was randomized one by one to OCT versus IVUS-guided PCI strategy. We included all common patients, just excluding semi-severe renal dysfunction without renal replacement therapy, or cardiogenic shock, or decompensated heart failure with severe LV dysfunction. The primary endpoint was target vessel failure, a composite of cardiac death, target vessel MI, or ischemia-driven TVR at 1 year. Secondary endpoint had the individual components of the primary endpoint and bleeding event and contrast-induced nephropathy. We assumed a 1 year event rate of the 8.0 with a 3.1% of the non-inferiority margin. The details of the imaging optimization and the process of the imaging-guided PCI will be presented by the next lecture by D.W. Park. We randomized 2008 and OCT-guided PCI versus IVUS-guided PCI. And over 99% of the patients underwent 12 months clinical follow-up, and 100% patient was included in intention to treat analysis. The key baseline characteristics shows that mean age of 64 and 33% of the diabetic patient and 23% of the acute coronary syndrome. And about 12% had the left main disease, and over 50% have the any bifurcation disease, and about 10% has the aortic ostial lesion, and over 5% has a CTO. And mean syntax score was 15. And major patients underwent PCI by radial access, and over 97% underwent drug-eluting stent implantation. Mean stent number was 1.6, and mean stent length was 47 millimeter. And total amount of the contrast media used was higher in OCT-guided PCI. However, the total PCI time was shorter in OCT-guided PCI group. This is a primary endpoint of target vessel failure. 2.5% of the OCT-guided group and 3.1% in IVUS-guided group at 1 year. They showed hazard ratio of the 0.80 and showed non-inferiority of the OCT-guided PCI compared to IVUS. And there is the detailed list of the primary and secondary outcome that showed no significant difference between OCT-guided and IVUS-guided PCI. And also, we had the CV outcomes during the entire follow-up period of the median 2.0 years, ranging 1 to 4.8 years. The primary composite outcome was the 5.8% versus 6.1% that showed comparable clinical outcome between groups. And also in secondary outcomes, there was no significant difference. And this is a key subgroup analysis by the clinical factors of the age, sex, DM, acute coronary syndrome, all showed no significant difference between groups. And there was also no significant difference by anatomical factors of the left main, diffuse lung disease, calcified lesion, or syntax score. This is the subgroup analysis by the bifurcation. In patients with any bifurcation disease, over 52% that showed event rate at 1 year, 3.1% in OCT-guided group, and 3.7% in IVUS-guided group. They showed no significant difference. And when analyzed only 2 bifurcation disease with the side branch disease, and about 21% has the true bifurcation disease, and OCT-guided group has a 3.8% of the event rate, and IVUS group had 5.2% and not significant. And also there was no interaction between true bifurcation disease and imaging guidance. And there are some limitations of the study. It was not possible to match the imaging modality from the patient and investigators. So there is the possibility of ascertainment or selection bias. And the observed number of the primary outcome events was lower than expected. And there would be the possibility of the discrepancy, on-site determined, and core measured imaging interpretation. And the generalizability and reproducibility of our trial findings may be limited due to geographic variability in the use of intravascular imaging in daily practice. And our trial did not include an angiography-guided arm. This is a summary. In OCTIVUS trial involving patients who are undergoing PCI for diverse coronary artery lesions, OCT guidance was non-inferior to IVUS guidance with the composite of deaths from cardiac cause, target vessel MI, or ischemic-driven TVR at 1 year. And OCT and IVUS-guided PCI also showed comparable clinical outcome in any or true bifurcation lesions. Thank you for your attention.
Hey, thank you very much, Dr. Kang, for an excellent presentation, and congratulations to you also and to the whole team for this very important clinical trial. Now I invite Dr. Park to take a deep dive into OCT IVUS trial.
Thank you for inviting the EBC 2023 meeting. I'm D.W. Park from Azzano Medical Center. So my talking is about the OCTIVUS trial. It's a deep dive into OCTIVUS trial optimization criteria and protocol. And looking at the background and the intracoronary imaging IVUS or OCT is recommended in selective patients for optimized stent implantation. And US and the ESC guideline recommended, especially in complex region. Our OCTIVUS trial included 2,000 patients, one-to-one randomization OCT versus IVUS, and primary endpoint was target vessel failure at 1 year. Our inclusion criteria, we would like to include a broad range of the patients, native or restenosis, and treated with contemporary drug-eluting stent. And minimal exclusion criteria was applied. Looking at the imaging guided PCI procedure, conventional PCI method was used, and the conventional device for IVUS of OCT was used, and the stent size and length optimization. The segment was determined use predefined common algorithm on the basis of EA-PCI. And looking at details of our optimization criteria, regardless of IVUS or OCT, we use the distal lumen reference-based diameter or EM reference-based sizing strategy. If you're going to use the lumen reference size, we are the up rounding of stent size, the reader, and if you're going to use EM, we are downsizing on nearest 0.25. We would like to avoid the landing zone in the large plug area, and the relative stent expansion more than 80% we would like to achieve. Some patient, some region with a non-available reference lumen area, optimal stent expansion was defined the absolute instant minimal stent area more than 5.5 by IVUS and 4.5 by OCT, and the core registration was used. So, and for diffuse long region and more flexible approach, lumen and the middleware or EM was allowed by physician discretion. For left main disease, minimal stent area for distal left main is more than 7, proximal left main 8 was recommended, and the extensive stent malposition is tried to be avoided. Our trial is one-to-one randomization nearly at 1 year, more than approximately 90% was completed follow. This is the baseline characteristics, and the age is 64. Male gender was predominant. Diabetics is 30%. It's quite the comparable between two groups. And our trial included the complex coronary region, left main 20%, any bifurcation region, approximately half of patient, true bifurcation region 25%, and the CTO diffuse region, ISR region also included. So overall, the procedural outcome, imaging basis, the procedural success was achieved. There is 48% in OCT-guided PCI, 54% in IVUS-guided PCI. Overall procedural complication is lower in OCT group 2.2 versus the 3.7. And this is core analysis, the region level analysis. Minimal stent area is lower with the OCT than IVUS, and looking at the optimization imaging guided PCI criteria, by region level analysis, all stent optimization criteria was met, achieved in the 53% in OCT group and the 60% in the IVUS group, and the optimal stent expansion was larger in IVUS, and the meta position and the larger dissection was much detected in OCT group. The reason why the overall the proportion without the major meta position large dissection is quite low in the OCT group. Primary endpoint is target vessel failure. As everybody knows, no difference error is non-inferior. So, and each type of cardiovascular outcome, there was no difference in the target lesion failure and mortality, myocardial infarction, contrast-induced nephropathy and stent thrombosis is quite few. And the pre-specified key subgroup analysis was consistent in various clinical factors, also consistent in various anatomical factors, left main, bifurcation, long lesion, multivascular, and the each syntax score category. This is a post-hoc analysis by optimization criteria and the presence or absence all PCI optimization criteria. Each component of optimization criteria overall finding was consistent without the significant statistical difference. In summary, our OCTIVUS trial OCT-guided PCI was non-inferior to IVUS-guided PCI in target vessel failure at 1 year. However, study population was selected and lower than expected event should be considered. And the last slide is the benefit of intracoronary imaging. The largely depend on off-rate interpretation and the reaction to imaging finding. There would be possibility discrepancy on on-site determined or correct measured imaging interpretation. Full optimization PCR result was only achieved in approximately half of patients. Therefore, further study are required to confirm the validity of such predefined optimization criteria. Also, and the new study was required to propose the new practical optimization criteria. Thank you for your attention.
Okay, thank you very much, Dr. Park. If there are any questions, please do yes, Nicolas.
Yes, Dr. Kang, Dr. Park, thank you very much for this presentation. As I was reading your manuscript, I was surprised by the percentage of osteal lesions in both groups, which was between 9 and 10%. And in our experience, the osteal lesion that could be in right coronary artery or left main are not very good candidate to OCT imaging, but they are very excellent candidate for IVUS imaging. So I was wondering how you overcame this difficulty in your trial and the recommendation you provided to the different teams.
Okay, Do-Yoon.
Yes. I'm sorry in advance for the background noise because I'm attending other conference. And as you said, the osteal lesion is not a very good candidate, especially for the OCT because it needs contrast filling. So the osteal lesion was not only for the very osteal lesion, but including the osteal and very proximal disease that covers the stent up to osteal lesion. And even there was some difficulty, especially with the OCT, but there was some techniques that could overcome the difference. We have used some guide in and guide out technique, or sometimes we use some guide excision catheter to evaluate the osteal lesion exactly. However, still I think that even the subgroup analysis shows no clinical outcome difference between OCT and IVUS even in osteal lesion. However, for the procedure, practically, I do not strongly recommend OCT for the osteal lesion.
Thank you.
Okay, Alessia.
Yes, thank you for your presentation. I have a question for Dr. Kang. About the result that you have shown, the target vessel lesion, it seems to be a bit less for the bifurcation, for the through bifurcation lesion in the OCT-guided PCIs versus IVUS-guided. Do you have any idea why it is happened? And this is just a tendency, is not significant, but I think is relevant and interesting to understand why it is happening. And then another question is, this is even shown that target vessel failure was a bit less in the group with syntax score low, with the low score or syntax. Despite we said right now that with complex bifurcation or through bifurcation is already complex, so we expect to have higher syntax score.
Thank you for your excellent question. That's a very difficult question, and we have so many consideration how to explain those differences. But it's actually not very different. So there are some tendency, but so first of all, it can be by chance. It can occur by chance. And second would be that the procedural, the complication was a little bit lower in OCT-guided group. We think that more aggressive balloon expansion and larger sizing with the IVUS could make some such a kind of the complication in IVUS group. And even in the also in the true bifurcation group with the side branch treatment, that could make some difference, I think. But still, this is not just a hypothesis because it's not very different between groups. And so we are undergoing the further evaluation with the bifurcation patient and true bifurcation patient. And with that, those thorough evaluation with the imaging analysis, we could show you more detailed data.
So the OCTIVUS trial initially designed as a pragmatic trial in the real world, in the many centers in South Korea as a very familiar is a post-imaging modality and imaging in IVUS more than 10 years. Absolutely the many expertise, the imaging guided PCI. So, and in our trial, we'd like to include a broad range of the patient, but it's beyond our initial expectation, even though we try to include the very complex, diverse the patient. Overall mean syntax score is quite low, it's 15 and 50.6 in both groups. So that is the reason why the primary endpoint, the event was absolutely lower than expected. This is the major obstacle to demonstrate it, to confirm the real non-inferiority of our OCTIVUS trial.
Great.
And there can be some other hypothesis that can be got in by the syntax score, because even a high syntax score, we actively use the physiology FFR guided PCI. So the anatomic syntax score is not same with the treated vessel. And also there was some case with the staged PCI in high syntax and multi-vessel disease. So we did the subgroup analysis with the index multi-vessel PCI. However, syntax score is not 100% correlated with the index region PCI.
Thank you. I think Dr. Christiansen
I have a question, if you can hear me.
Yes, we can hear you.
Yeah. Thank you. I have a question to the OCTIVUS team about the strategy in the OCT arm in the calcified lesions, where the operators, because of the identification of the depth of the calcium, push to more aggressive pre-dilatation or post-dilatation?
Absolutely. Okay.
Yep.
Okay, your comment is so important. In our trial, in both group, and the overall proportion of the severe calcified region, 7.6% and 7.6%, less than 10%. Also, looking at the detail of the pre-region preparation, and we use the compliant or non-compliant balloon 75% and 75% in both group, and the scoring of cutting balloon just use the 1%, low tabulations, they use the 1.0 versus 1.5%. Overall use of the atherectomy and some debulking method was quite low. So, and absolutely, I fully agree, OCT absolutely better to determine the calcium severity. But there's overall the use of the debulking method is quite low, and in the next step we would like to see there would be some difference in the further analysis.
Yes, great. And we recommended a very strong post-dilation and further optimization by imaging. So over 90% of the patients underwent post-dilation with the mean post-dilation balloon pressure 22 atm is a mean value. Very high pressure was applied. And there is a little bit difference in supplementary material. You can see that adjunctive post-dilation was a little bit higher in OCT group. 92% versus 89%, 7%. Small difference, but a little bit significant. And it can be from the difference of the detection of the post-viral position or the calcium. So we need more further analysis of the cause. Thank you for your great opinion.
Okay, thank you so much, Dr. Kang and Dr. Park, and congratulations again on your trial.
Thank you.
Okay, now I'd like to invite Davide Capodanno, who I think has already sent in his presentation, to discuss the impact of all these studies on clinical practice.
Dear chairpersons, let me thank the EBC board for giving me the chance to comment on the latest evidence from imaging trials at the end of this session, and I will give you my perspective on the impact of these new evidences for our practice. This is my disclosure of financial interest. As you know, in 2018, the ESC and the ICTS issued a number of recommendations in support of IVUS and OCT with class 2A level of evidence B or C. And you may say that the class of recommendation is only 2A and the level of evidence is only B or C because these guidance from Europe were outdated. They are 5 years old now. However, even in the more recent guidance from our American colleagues, we still see class 2A level of evidence B or C for IVUS or OCT. So what do we need in order to get the class 1 level of evidence A for intravascular imaging? According to the ESC Charter, for a class 1 recommendation, we need evidence or general agreement that a given treatment or procedure is beneficial, is useful, is effective. And for a level A of evidence, we need data derived from multiple randomized clinical trials or meta-analysis. We now have the randomized clinical trials, however, the results were mixed. In ILUMIEN IV, there was no difference between OCT and angio-guided PCI for patients with diabetes mellitus or complex coronary artery disease in target vessel failure at 2 years. However, in the October trial, the primary endpoint was actually met. Cardiac mortality, MI, and ischemia-driven revascularization was significantly reduced with the OCT-guided PCI approach versus the angio-guided approach at a median of 2 years, from 14.1% to 10.1% in participants with the complex bifurcation CAD. It is of no surprise sometimes that trials in the same scenario end up with different results, especially when the type of patients and lesions that are included are different. For example, in ILUMIEN IV, which was a larger trial, by the way, the proportion of patients who received treatment of bifurcations with 2 stents was 3% versus 64% in October. The stent length was also different, with the longer lesions treated in ILUMIEN IV, 41 millimeter versus 23 millimeter, and the reference diameter was also different, with smaller vessels in ILUMIEN IV, 2.9 millimeter versus 3.3 millimeter in October. I would say that a key difference was also the performance of the angiography-guided PCI group, the control group, 10.1% of event in ILUMIEN IV versus 14.1% of event in October. So the result was different, with no difference in ILUMIEN IV and 30% relative risk reduction in October, as we have listened. And this is the network geometry of the meta-analysis presented by Gregg Stone at the ESC. Essentially, there are many connections between angio and IVUS, angio and OCT, OCT and IVUS, and there was also one external node given by the Renovate complex PCI trial that compared OCT or IVUS at the discretion of the operator versus angiography. So now we have quite a few trials, and of course the interest for a network meta-analysis is pretty obvious. The beauty of network meta-analysis to make direct but also indirect comparisons between the different nodes, and of course we are quite happier when we see consistency in the results of the direct and indirect comparisons, which never happened in this meta-analysis essentially, although the p-value for consistencies were non-significant. But you see that in the intravascular imaging versus angiography meta-analysis, the network benefit was all direct, which is positive in a way. The same for the IVUS versus angiography network meta-analysis. However, when you look at the OCT versus angio and OCT versus IVUS comparisons, you see that the benefit seen in the OCT versus angio comparison on the network meta-analysis is all indirect, 50% of benefit, and in the OCT versus IVUS comparison, there was even no benefit in the network meta-analysis and arm in the indirect meta-analysis. These indirect comparisons benefits or arms tell us that there was no real transitivity between the OCT trials and the IVUS trials, so we need to be quite cautious here in extrapolating these results to a whole population. In terms of the other endpoints, I think this is another difference that comes obviously from the meta-analysis. The benefit of the intravascular imaging versus angiography comparison is essentially attributable to the IVUS versus angiography trials, where there was no benefit in OCT versus angio, as well as in OCT versus IVUS trials. This meta-analysis doesn't include the results of OCTIVUS, and it's a pity because these are 2,000 patients with significant coronary artery disease and a PCI, so it would have been a beautiful fit to this effort. And you see that in this trial, there was essentially non-inferiority for the OCT-guided approach versus the IVUS-guided approach. Although we must say that the number of events that were counted in the IVUS group was much lower than anticipated. The proportion was 3.1% versus 6.2% anticipated by the investigators. In this scenario, it's important to recognize that the lower than anticipated event rate may bias the trial towards non-inferiority. In other words, it's easier to reach non-inferiority when you have less events than expected because your non-inferiority margin would be too generous at that point. However, if we recalculate the non-inferiority margin for this trial based on a better statistical assumption, essentially we end up with the same results of non-inferiority. This is because the trial had actually very similar rates of events in relatively simple patients and lesions, as you can understand from the number of events overall. If we include the results of OCTIVUS into the pairwise meta-analysis of OCT versus IVUS, so we end up with 5 trials, and again, a neutral result in terms of target lesion failure. The relative risk is 0.82. The confidence interval is still quite large, which means that we simply need more randomized evidence for this comparison especially. In summary, I would say that supported by evidence from clinical trials and meta-analysis, IVUS consistently showed substantial reductions in cardiac events. This foundation, in my opinion, supports the elevation of IVUS to a class 1A recommendation, at least in cases involving complex bifurcation lesions, such as left main or non-left main bifurcation lesions. The evidence for OCT is definitely accumulating, but as of today, it is mixed, and in my opinion, remains less persuasive, at least for non-bifurcation lesions, as October was actually positive. IVUS and OCT, however, should be seen more as complementary rather than mutually exclusive techniques, so each operator should choose the technique he is more confident with. And finally, remaining questions include who are the optimal candidates to IVUS or OCT, the strategic timing of their application, which technique is preferable, and the perspective of healthcare payers and regulators, particularly in countries where intravascular imaging is not reimbursed. With that, I would like to thank you for your attention.
So I think that Davide really summarized very well the results. Are there any other remarks from the trialists that we have connected? Just okay, Greg.
Yeah, well, thanks. Davide, as always, does an excellent analysis, but I do have to try to convince him that we have enough data where the results of OCT guidance look really similar to IVUS guidance. I will share my screen for a second, and I'll show you the one slide which is the updated analysis, and Davide showed you his background, but this is the full network meta-analysis of OCT-guided PCI versus IVUS-guided PCI, and these are all the different endpoints. We have 5 clinical trials with 324 patients, and if you look at the direct estimates actually all favor OCT. None of them are significant, but they actually all favor OCT and not, inconsequently. TVMI 0.63, stent thrombosis 0.67, et cetera. But that only leads to about, anywhere from 30% to 50% of the evidence. Here are the indirect evidence, and then that's the percent of the indirect evidence. So here's the overall network estimate. And the bottom line is when you look at this network estimate, they're very, very similar for every single endpoint between OCT and IVUS. And the hazard ratios are not, or the relative risks are not that different. I mean, they're reasonably tight. They could always get a little bit better. But for TLF, the primary outcome, 1.08, 0.89, 1.33. So I think that the data that we have so far, at least for all lesion types that have been enrolled in these trials, is that the results of OCT and IVUS guidance are pretty similar.
Thank you very much for sharing these new results. So I think that now the session can be closed, at least with this slide. I think that we can say that the evidence seems enough to say that OCT is comparable, effective with IVUS, and regarding the search for the patients who may benefit more from imaging, there is still some work to be done. Thank you for your attention, and we go. Thank you to the trialists for connecting. It was wonderful, really. Thank you very much. And we go to the other session. Thank you.